group has been working with the World Health Organization in a two-pronged way. The first is we actually wanted to look at the data and see how well HIV self-testing is working now. And then, as you say, we wanted to use modeling to either take those data and say, well, what does this mean for the next decade? Or what does this mean in terms of transmission, as well as some assumptions, some of which we don't have data for yet, such as HIV self-testing for PrEP, and ask, well, what could this mean? So on the data side, it's interesting. As I mentioned, there have been randomized controlled trials of HIV self-testing where you go to this community and you make sure, let's say it's available in the clinic waiting rooms for people who are seeking any kind of medical care. In these communities, you don't. And you look at the effects on, for example, how many people are coming in to become diagnosed and initiate treatment. But there hadn't really been an evaluation of HIV self-testing in the real world, so to speak. So as countries have seriously invested in this, they've bought large amounts of tests, they've shipped crates of those tests out to health facilities, but there hasn't been a project that said, okay, well, what impact has that had? So we've actually partnered with local health departments in Kenya, Zambia, and South Africa to look at the data on which facilities are getting these crates of tests. Some countries have data on who ended up taking those tests home, others don't, and then different outcomes. And we are actually able to infer an effect. So how many more people will I diagnose per 1,000 tests that I ship to the clinic? So that was the first thing we did, and the results look very encouraging. And then we started to ask some of these what if questions, such as, well, what if self-testing were broadly used to support PrEP? And what if that enabled pushing PrEP to private pharmacies or to community health workers? And there, our colleagues at University of Washington did a literature review and tried to make an educated guess about how many more people would access PrEP, although we don't really know. And then we're able to see how is that going to help us move toward epidemic control, by expanding PrEP coverage. The presence of self-testing and the fact that it had been rolled out in the nick of time for this funding situation has been a blessing. It has been a help. First of all, because there have been challenges having ordinary rapid diagnostic tests available for people who need to get that first stage of diagnosis so they can link to care. And some settings have fallen back on HIV self-testing as a way to backfill gaps in commodities for testing. And moving beyond that, HIV self-testing, when it's used as a triage mechanism so that the provider doesn't have to spend as much time with people who test negative, who don't need PrEP, it's enormous because it really helps countries save costs. So they have to pay those people. And I think even more so than costs, we have to remember that brain drain is real and that the health worker cadre, it's a limited group and it can be a hard group to expand, especially when you're cash strapped. And so being able to provide as much high quality care as possible with a really limited number of people and amount of human resources for health, that's going to be a lot of the game that these countries have to play now, now that there's been both staff and funding withdrawn. So I think self-testing, it's been part of the solution, really. It was originally envisioned as a way to be more ambitious on top of these programs, but what it's really doing is sort of helping to save the day and keep the services that were there running smoothly.